Okay, I am going to introduce you to Dr. Martino from the Cummings School of Medicine, Department of Clinical Neurosciences at the University of Calgary. Dr. Martino will be presenting now and will follow up by a 15-minute question and answer session. So please join me in welcoming Dr. Martino.
So it is possible that some of you may have met me already one or even more times. I've been collaborating and working with with DMRF Canada for a few years. I relocated from the UK at the end of 2016, so I've been working in Calgary for almost 9 years now. And as you can tell from my accent, I was not born in the United Kingdom or in Canada. I'm Italian, and I think it means for me a lot to have the opportunity to share time, conversation, discussions with people living with dystonia or living close to people who have dystonia. Simply because, for a very simple reason, I have been into medicine, which means dating back from my first year of medical school, 33 years. And 28 of these 33 years have been directly and pretty regularly exposed to dystonia in my professional life. So I think probably my interest and in dystonia coincides with the interest in my overall profession. In fact, dystonia has been the first movement disorder I was exposed to in a body where I come from, which is the heel of the boot of Italy, in the southeast, and which is also the first university where botulinum toxin has been applied regularly to treat dystonia in Italy. And so I already found a great experience on dystonia when I started, and then as a medical student, then as a resident, then as a movement disorders fellow for my subspecialty training, and then when I started working. So I never really stopped interacting and looking after patients with dystonia. In the past 10 years, I have been more interested in in aspects of dystonia which go beyond, a little bit beyond what we typically define as dystonia, which is a movement disorder. So there are motor features that are essentially the core features for which one gets a diagnosis of dystonia. But in the last 10 years, I've been interested, and more probably, I've been interested in understanding why, how frequently, how impactfully people with dystonia also have other features. Because the same thing happened to Parkinson's disease. I mean, Parkinson's disease was considered just a movement disorder. And in the last 25 years, it became clear that it's way more than that. I'm not suggesting that the same breadth of spectrum applies to dystonia as well, but certainly dystonia is more than just a movement disorder. And this has been clearly corroborated by clinical research over the past decade and more that has clearly shown how, and again, my main experience is in adult onset, isolated or idiopathic dystonia, but I of course have developed some experience in other forms of dystonia, in myoclonus dystonia and secondary dystonias, tardive dystonia. But most of the concepts about the spectrum, on the breadth of the spectrum of dystonia apply to different forms of dystonia, not just the adult onset isolated dystonia. But being the adult onset isolated dystonia the most common, this is also where most of the evidence has been collected from. I was saying clinical research really has shown that quality of life of dystonia is not just impacted by involuntary movements, tremor, but has been impacted by other features that we would call non-motor, because they're not motor, but they are coming from different realms. They are coming from the emotional dysregulation, or psychiatric, if you will, aspects, sensory, such as pain, sleep, even cognitive, fatigue, and more. And it has become very clear that, you see, at the center of this diagram, you have all the domains of quality of life. And so general health, physical functioning, physical role functioning. So all the different domains of quality of life of dystonia, you can see how way more interconnected these are with the bottom row: depression, generalized anxiety, social anxiety. These are just the emotional features, right? Whereas there's a level of interconnectedness with dystonia severity and tremor that is lower, which indicates that, number one, that people who have dystonia may have also depression and anxiety in different forms. But it means also that if we ignore these additional features, we are not addressing extensively and comprehensively quality of life impairment in people who live with dystonia. Yeah. So this is the full spectrum of non-motor symptoms in dystonia. You will hear later from Dr. Shetty and then from the presentation of Jackie Townsend a lot about how to deal with motor features of dystonia. But this is just to give you an idea of what the field is focusing on when it comes to non-motor aspects. You see the psychiatric part. I should say probably that social phobia, social anxiety, generalized anxiety, and sometimes depression are most relevant. I don't think that obsessive-compulsive disorder is a common feature of dystonia, but it is a common feature in some genetic forms of dystonia, such as myoclonus dystonia. Sleep disruption is really an underrated problem in dystonia, which is particularly relevant. And it's essentially reduced sleep efficiency, reduced depth of sleep, as well as early insomnia, sometimes difficulties falling asleep. Pain, I mean, we all know that pain is almost as core as the movement disorder. Because of the muscle contractions, we feel that there's a component of origin of pain coming from the excess of muscle contraction. But there's also research showing that pain processing in the brain, in the central nervous system in people with dystonia is a bit altered, almost as if there was a lower ability of the brain to block pain signals from reaching the cortex. And so it's almost like there's a predisposition to have more pain than in the general population. There is some initial evidence of that. This is beyond, therefore, having pain because you are having a muscle contracture. Cognition, this is still very limited, not really explored. I don't think it's fair to say that we are concerned for people who have idiopathic dystonia or most forms of dystonia. Rare genetic forms or more rare genetic forms maybe are an exception to that, and there's so many that obviously we have to consider them one by one. But the general garden variety of cervical dystonia, blepharospasm, laryngeal dystonia, hand dystonia, those are, it would be really, unfortunately, it would be exaggerated and inaccurate to say that there is a risk that people with dystonia can develop dementia. So this is just a word of reassurance. But there may be subtle changes, particularly in the executive functioning domains, that can be present because they show up on studies that have been done, people with dystonia. And therefore, it is something that we have to keep into account and continue investigating in case this is having a larger effect on functioning and quality of life than one might think. And finally, fatigue. Fatigue is a very generic term in a way, because it can come from so many different aspects, and it can also be aggravated by not having had a good quality of sleep the night before, or it can be aggravated by the fact that one is feeling depressed or low in their mood, and certainly is coming from the constant, relentless muscle contractions that people with dystonia live with every day. But it's not something that we ever discuss with patients. I would pretty much say, if they bring it up, fine. Otherwise, we don't ask. So this is essentially to say that, okay, this is nice, this is interesting, and I imagine it is. But does this cohort of symptoms, is it reflected in the type of clinical care that people living with dystonia receive every day? Probably not. And this has to do with a number of different reasons. And one of this is models of care, access to care. How many of you receive botulinum toxin injections on a regular basis? That's a good number. I'm not sure if it's the majority, but it's close to 50%. And there may be many reasons for which others don't, and maybe has to do with the fact that they have generalized dystonia, and which is not easy to treat with botulinum toxin. But how much time? What is the average time spent with the neurologist in a botulinum toxin clinic that you have experienced? 7 minutes. Yeah, that sounds about right. Hopefully, it's on the lower end. It's below the median, hopefully, but yeah. And I don't recognize immediately any patient of mine, but I'm not better. So, and it's not. So yeah. Far from me the tendency to brag about spending hours with my patients. I wish I could. Obviously, I call this the curse of the botulinum toxin, the Botox curse in brief, because on one hand it helps symptoms for most people, not everybody, and for variable durations of time. So it's good. Thank God that we have botulinum toxin. It's a bit like levodopa for Parkinson's patients. It's important to have it. But on the other hand, because it lasts only 12 weeks at the most, you got to repeat it every quarter. And so you have to see patients 4 times a year. And it looks like, we recognize our patients. We see them all the time, so 4 times a year. How many patients are seen by their specialists 4 times a year, every year, pretty much? Very, very few. But it's like the quality-quantity mismatch, right? I mean, okay, maybe I see you a lot, but what's the quality of our relationship? Is it good? Probably not. Because if we only see for 7 minutes or 8 minutes or 10, then okay, we barely can say hi. Then you get the zip zap, and then you leave. You definitely spend more time in the waiting area than in the doctor's office. Is that good? No, it's not good. Obviously, could it be worse? Yes, you could not. You could not see the specialist at all. Of course, it could be worse, but we don't want that. We would like to have a model of care where things are organized in such a way that we can address other aspects too, and not just, we can barely examine our patients in that period of time. And the reason for this is not because we don't want to do that, or because we're lazy. It's because dystonia is the 3rd most common movement disorder. It's not. It's listed under the rare diseases and disorders. It's not a disease. I mean, by definition, it's a condition or disorder, but it's often accompanied by the term rare. In the field of movement disorders, it is not rare. And because it has so much overlap with another condition that you may have heard of called essential tremor. In fact, essential tremor and dystonia have a lot in common in mechanisms, and in fact, many patients with essential tremor have a bit of dystonia, and many patients with dystonia have tremor, as you know. So they're actually almost like the same spectrum, which makes dystonia probably the most common movement disorder, pretty much alongside Parkinson's. And so just this is a digression, but why is there so much attention and funding and research on Parkinson's disease and not nearly as much visibility for dystonia? This doesn't make sense, and it's a societal fault. It's a fault of health professionals and academics that have not probably advocated enough. Because, mind you, if you have we were hearing about research, and I'm freestyling a little bit here because I know I have to stop, but I'm saying most of the things that I wanted to say, so I'm not digressing too much. But what was I saying? Is that you heard from Archana that the DMRF Canada is very interested in investing on research, but researchers can only do their research if they have funding, okay? And once they realize that a field, no matter how invested they are in it, no matter how much they care for it, doesn't receive adequate funding, doesn't matter if you are doing great stuff, but simply it's not a priority for the government or whatever other major funding streams, they will go towards something else. Because if they want to survive professionally as researchers, they have to go where the funding is, right? And so they might abandon dystonia, and they go and might once again another one fallen towards Parkinson's, which is, but don't get me wrong, we want to see the cure for Parkinson's disease as soon as possible, but it's not the only disorder, right? And unfortunately, dystonia lives in this situation. We have to advocate at a societal level about it, and there shouldn't be any shyness in doing that. There should be also, in fact, there should be cleverness in strategizing. So if essential tremor is debilitating as it is, and is so close to dystonia, why not merging efforts and advocating together, for example? Mind you, essential tremor doesn't have an association that's nearly as strong and broad as DMRF can. They don't have an association, for that matter, like a national one. They have some support groups that are just coming up out of a spontaneous initiative of individuals living with the condition. So that's important to keep in mind. Because good research requires continuity of support. You can do a great study which sets the stone for the future, but if the future has no funding, this is where a great research avenue stops and has to face a block. And that's terrible, right? Whereas when one grant leads to another grant, to another grant, to another grant, this is how you build knowledge and how you advance the field. But in Dystonia, we are experiencing a lot of researchers who are starting fantastic things, have great ideas. They produce wonderfully interesting pilot data. At the time of getting the 2 million grant to actually make it become a new treatment, for example, they can't. So we have to be mindful of that. And this is, I'm not saying this to depress you all. On the opposite, I'm just informing you from my perspective, obviously, what are the challenges and what our community interest should focus on. We should change this, okay? Because this is changeable. So this is probably the only slide that I have that it's unreadable to you and to me as well, to be honest. But essentially, it's coming from a nice paper that summarized the long and winding road towards good clinical care. I don't want to read it all because it's unnecessary, and most of this because also you are the people actually who can teach me on this long and winding road. I only am on the receiving end, or I am a dot or a cross in all this, but you have lived it all, right? And so there are many issues that have to do with misdiagnosis. For example, taking dystonia for something else. You should remember that dystonia, before it was liberated as a neurological condition, was considered a psychiatric problem entirely. Now we are recognizing some psychiatric issues within dystonia, but dystonia is a neurological condition, not a psychiatric one. And then other common problems are, of course, the waiting time to see a specialist who understands dystonia, because not all neurologists know about dystonia. Not all only a very small number of neurologists or a minority of neurologists are familiar with, for example, botulinum toxin treatment. So you need to see an injector, a neurologist who is also a movement disorders expert, or at least an injector, and has developed some experience in using botulinum toxin. And typically, if they don't have a lot of experience in adult onset so what we call erroneously focal dystonias, like cervical dystonia or others, let alone will they have experience in more rare forms of genetic dystonias, other forms of generalized dystonia. Even drug-induced dystonia may be difficult, maybe a difficult topic for these neurologists who are not trained in movement disorders. So you have to see a movement disorder specialist to really get good care for dystonia. There's no escape to that. There's really no escape to that. And then what happens is that even amongst the injectors, there are differences. You have one person who would prefer to use a certain technique of injection, another one who uses another one. All this heterogeneity is also slightly problematic and may lead to some dissatisfaction. But I can tell you that that's probably, once you are there, once you're seeing a patient, a physician or neurologist who does botulinum toxin injections, you already are pretty much at the end of this long and winding road. One thing that I would strongly encourage, there's a general tendency to see botulinum toxin treatment, and Dr. Shetty will tell you about this, as an art. It's a form of art, which is true in a way because we don't learn it on books. We learn it based on experience. We are imprinted by our trainers, our mentors, our teachers on how to administer this treatment. But there are different ways to approach this treatment, most of which are correct, because most of which truly overlap. But there is a general, I hear sometimes, and this is something that I personally don't do, but some colleagues addressing botulinum toxin treatment and the way they administer it as the best way to do it, okay? Prepare yourself for a little shock. There is no best way to use botulinum toxin. There is not. There are many good ones, okay? So sometimes you will find a physician say, oh, I am the Mrs. or the Mr. Come to me. I never say this to my patients. I'm going to try to help you as much as I can. And if it goes well, if not, we'll find remedies. And if I'm failing, I ask for a second opinion one of my colleagues, we have so many injectors in our movement disorders clinic in Calgary. We're quite fortunate. We have 9 injectors in Calgary, which is not plus a couple in the community, 2 or 3 in the community. So we're not doing too badly, I think. Yeah. So that's often something that happens. And then, of course, you'll hear from Jackie's talk and later on also the issue of accessing other type of therapies, allied health, particular physiotherapy. I have become more encouraging towards physiotherapy than I used to be in the past. The evidence hasn't changed. There's still no good evidence about physiotherapy treatments in dystonia. But I realized that dystonia is more and more understood by physiotherapists. And so even if there isn't one good protocol that has demonstrated great efficacy in more superiority compared to others, I still think that there is a scope for. I now am more convinced than in the past that there is a scope for physiotherapy in dystonia, particularly in cervical dystonia, and that should be leveraged in some way, because there are more and more therapists who understand dystonia better, physiotherapists who understand dystonia more, and so you'll hear more about it. She will tell you about. I think what you should know are the principles of physical therapy. Because I have a couple of slides of that, but I don't want to be redundant because she will talk about it a lot. But I think you should know what are the main principles of how to approach physiotherapy in dystonia. Mostly to run away from people who are not nearly as close to actually addressing those principles and are offering you strange forms of stimulation or strange things that are not. They really don't have not even an evidence basis, because we know that common physiotherapy approaches don't have a strong evidence basis, unfortunately. But they don't even have a rationale, right? Whereas you could do good physiotherapy if you are starting and basing your premises on good core principles and rationales, even if what you're doing is not supported by a large amount of evidence. And because the reason for the latter is that there haven't been the studies to do that. But botulinum toxin proved its effectiveness way before the first good clinical trial, confirming its efficacy. And we are using it now. We have no doubt that it.
Good. We're going to open up the question and answers again. Dr. Martino has agreed to stay on and answer the outstanding questions that anyone has. So, Julie, we'll bring you the mic.
Dr. Martino, thank you very much for agreeing to answer some more questions. I am very new to this path. It was less than 2 years ago I was diagnosed with cervical dystonia. I have some great clinicians, both at the Glen Rose at the Peripheral Nerve Clinic and at the Arthur Child Center in the Oncology Physiatry program there, who are injecting me with Botox. Just wondering, how do we know we're on the right path with the right clinicians? Is there like a center of excellence or a path that we can suggest to our primary care physician or other clinicians we're seeing to make sure, can we look at this sort of thing?
So it's, if I understand correctly, you are not in a movement disorders clinic.
No.
Well, those are the centers of excellence for cervical dystonia. I mean, I don't wish to diminish the care you're getting, but those are the services that provide that have the greatest experience. And we have 2 in Alberta, one in Edmonton, one in Calgary.
Mm-hmm.
And those are, if you're asking for that, I think it makes sense to at least get an opinion from them. And if And then if they all agree with what you are already, the treatment you're already receiving, then there's no need to change, obviously. But or at least there's no, if there's no discussion about that, then it's all good. I mean, you had your question answered. But I think that so far movement disorders neurologists are still the best experts in cervical dystonia.
So is it a discussion with my current neurologist to get referred to a neurologist who specializes in movement disorders?
So is this neurologist injecting you?
No, he's not.
So you have two different physicians, one who injects and the other one who follows.
It's complicated. I'm seeing the Glen Rose for radiation-induced brachial plexus neuropathy, and the Arthur Child Center are actually doing my Botox injections in my neck for my cervical dystonia.
I think it's fair to ask, can I see a move? If I have a movement disorder, why can I see movement disorder neurology? I think it's fair to ask. Maybe not the provider who is doing the injection, maybe your family physician, but or whoever you want to ask. I mean, I think it's a fair question.
Yeah,
absolutely.
Thank you.
Yeah.
We have one more question.
Hi, I have a question. I'm thinking down the road, when I get in a nursing home, I hope I don't, and that I can't get out, would there ever be a chance of injectors to come into the nursing home to help with the dystonia, or is it something that I'm going to have to just suck it up and through my later years in life?
I am not aware of this happening at the moment in Calgary, for example, but I don't. It doesn't sound like a particularly complex. I think it's not so much to get the toxin to the long-term care facility. It's rather having some form of contractual agreement between AHS and long-term care facilities to have injectors going to long-term care facilities. So this is what we do with long-term care facilities. We provide a physician-to-physician phone, usually in most cases. And in some cases, we can also offer, for very complex cases, our program is open to do inside clinics. Question is whether there is capacity to provide botulinum toxin injections on a quarterly basis for several people. Everything can be arranged, can be discussed. So, from a technical standpoint, it's not difficult. It just it's a purely organizational, and it will depend mostly on the need. On the other hand, people can move from long-term care facility to clinics, and this happens all the time. Even people who are more disabled and wheelchair bound, they come and to receive the treatment in clinic as well.
We just couldn't take it. It was impossible. So that comes.
Yeah, and this is a case-by-case decision. One has to obviously choose the least invasive and the least invasive option. But in very specific cases, I see this as something potentially doable. But
And we have our next question.
At one time, I was the leader of the Calgary group, and there was a lot of people and a lot of dystonias represented. A number of our members offered, there's still a lot of neurologists who do not recognize, that I understand, do not recognize dystonia. And so a number of the groups said, well, when you are teaching that particular section, we will come and you can see what it is, how it works. And we were always told, we have videos. But to our mind, it made more sense if people were there who actually had different kinds, and they could say, okay, what happens when you do this? or what happens when you try to not blink or speak, that it was a little more realistic to have a real body there. Now, we were told, like I say, it wasn't necessary, but do you not think there's a place in the education of neurologists that real people might play a part?
Well, all neurology residents, so all people who are trained to become neurologists, they come to movement disorders clinics. They see movement disorders patients. They see patients with dystonia. And more than once. So this is happening now for residents, for people who are already neurologists, as a part of a continuous medical education. Frankly, so the ones who are truly interested, they would ask a colleague to attend perhaps a clinic or more, just to refresh their knowledge or familiarize better. But the residents are all rotating in movement disorders clinics. They all have to do that. And so they are being exposed to real patients.
I'm glad to hear that, because I think for a long time that wasn't really the case, was it?
No, probably not. You're right. We're talking about, some time ago, probably before I was even here. But no, now it has to happen. There's no doubt. We do several things. They come to clinic. They see patients on their own with our supervision. The ones who are truly most interested, they can even inject or try to learn how to inject. We do also tutorials. We discuss also video cases, because with video archives we can show in one lecture, in one session, we can show a variety of different things, which is not, we don't get this diversity necessarily in clinic every day, right? So yeah, no, it's happening. It's definitely, movement disorders is being taught better now. There will always be someone who doesn't recognize dystonia, but yeah, it's definitely an important part of training for neurologists. Yeah, in Calgary and everywhere else.
We have a question from Marcy.
Hi there. So I have cervical dystonia with arthritis in my neck, and I receive radio frequency ablation every 6 months for the pain. What are your thoughts?
For the arthritis, you mean?
Yes, but it does help with the cervical dystonia pain also.
Well, it helps with the pain.
Yeah.
And the pain is probably coming from the arthritis. And it's very difficult to differentiate between pain coming from dystonic muscles and pain coming from the cervical spine. It's just pretty much all there, right? It's not easy to say where is the pain coming from. And the chances are that if you are using specific treatments that are focused and targeting the arthritis of the cervical vertebrae and joints and discs and joint structures, then it's so. This is an important part about neck pain in cervical dystonia. It may be caused by different things. It is not just the dystonia. It's not just the dystonia feature. It could be a sign. It could be a symptom of wear and tear. It could be a sign of spondylotic changes, of the degenerative changes of the C-spine. And this is very important, particularly in those cases who are patients for whom we are discussing deep brain stimulation. Because they are maybe getting a reasonable response on the movements by the injections, but the pain is still there, and this could be pain coming from the dystonia, but it could also be coming from the arthritis. And if they get DBS, they're not going to get better pain-wise because deep brain stimulation doesn't treat arthritis, treats the dystonia. So it is very important when we're dealing with significant neck pain to investigate if there is arthritis of the C-spine, because in your case, I think, or in the case, in this case, it's most likely that the procedure is helping the pain related to the arthritis, which can be the arthritis can be aggravated by the movement. I mean, it is obviously true. It's mechanical chronic trauma coming from the continuous movement that can cause wear and tear of the C-spine. We know that, and that can lead to a significant buildup of pain.
Dr. Martino, we have one question over here.
All right. So I was talking to you earlier, but I didn't quite ask this question. In the event that an early diagnosis isn't made, can paroxysmal dystonia or dyskinesia trigger or cause frontal temporal lobe epilepsy as a separate diagnosis?
So basically, you're asking if we don't treat early paroxysmal dystonia, can it lead to seizures? No, those are very different phenomena.
Okay.
They can coexist in the same patients because they can both come from the same genetic variant causing.
Okay.
But they are not. But not treating the dyskinesia doesn't lead to a greater chance of developing seizures.
Okay. All right.
Or vice versa.
Okay.
Not treating the seizures doesn't lead to increased likelihood to develop dyskinesia in that particular.
I started having symptoms from, I can recall, as early as maybe 4 years old, but it was regarded as nothing. They didn't acknowledge it or anything. So it was pretty abnormal and rough growing up with it. Because, of course, with the type of dystonia I have, I can have up to 50 episodes per day. And it's the entire body. So it's pretty rough. So I was diagnosed with temporal lobe epilepsy 3 years ago. So I didn't have like any epileptic seizures full blown, but that was what it was acknowledged as me having. So my child started having the symptoms where she was falling, busting her mouth, at the top of the stairs. Principal had to run to get her and all of that. So that's how I identified with her what was happening. And then my push from New Brunswick to come here to get some form of help for her, they did the genetic testing because I couldn't provide any answer as to what was going on. And it was pretty complex. Seemed rare to them, everything I was telling them. So that's why I got that. So my concern is that my child would probably, have epilepsy, but her MRIs, EEGs are clear, but mine isn't. So I'm still having continuous episodes of epilepsy going on in the brain back to back, and it's still daily right now. So I was wondering if it was connected in any way. So that's...
Well, it's connected, but
Separate.
there's no relation between the delay in diagnosis and treatment of one symptom, or one type of episode, with the likelihood of having the other type of episode. The two things are, it's a syndrome. So so your question was if
it was connected in any way or triggered by one triggered the other.
So those are two different questions.
Okay.
Okay. They are connected because they have the same cause, that genetic variant, but they are not, one is not leading to the other, or one is not causing the other.
Okay.
And having delayed the recognition of one hasn't led to a greater chance of manifesting the other. They would have happened anyway.
All right. So in essence, I have a specially wired brain. Yeah. All right. Thanks, though.
It is possible to with that condition to have these different manifestations. Unfortunately, yeah.
We have 5 minutes left. Anyone else with one more question?
Well, there's also another question that it was in my list that I wanted to answer. It's a very quick answer.
Hello, and thank you for taking my question. My son, who's 40 years old, has cervical dystonia, retrocollis, and we in the healthcare system went through, and all of the clinics that we tried to get into the movement disorders here in Edmonton or in Calgary was like capacity, we're at capacity. So we finally got one neurologist in Edmonton who Brandon had his first Botox last week, Friday, not yesterday, but last week. So my question is, if it's not working there, how do we get into, like you just said, go to a movement disorder because they're kind of the creme de la creme of the, the knowledge about this. The system just seems to, what's the word? If they're at capacity, oh well. That we spent months waiting.
Being at capacity, and first of all, I'm sorry for this is one of the big issues is the delay in being seen. There are 2 clinics, which means that there is a limited number of neurologists working in these 2 clinics. So being at capacity, I don't know how to interpret that, in the sense that in Calgary we don't reject referrals because we are at capacity. Simply, the waiting time could be up to a year.
Yeah, 18 months we were told.
12 to 18 months. It is possible, which means that at some point the appointment will come. But the reason for that is that we are the personnel that we are, and we are already allocating for each appointment an adequate amount of time that is not long. So to improve this, it would be the AHS should hire more movement disorders neurologists. Simple as that.
One second part. Thank you for answering that.
Yeah, yeah.
I have one other quick question. Rolling the eyes up, like the eyes rolling back, as well as deteriorating speech, are they part of dystonia, or is that something totally different? My son is deaf as of a childhood, so his speech is even way harder to understand. Is that part of dystonia?
Rolling the eyes up, it depends on. So there are particular events that are triggered by drugs, in particular, like antipsychotic drugs. I don't know if there's been ever exposure to neuroleptics or antipsychotic drugs in this case, but right, yeah. So it could be. So we call them ocular gyric crises when they are a little bit sustained, and they are seen in some genetic dystonic syndromes. They're also seen as acute reactions to neuroleptics, but they are seen in specific, including some dopa-responsive dystonia syndrome. So it is possible, but I obviously I would have to know the whole history and examine and everything. Yeah, they're definitely, we call them ocular gyric crisis when there is this sustained eye rolling. Yeah, and the speech can also be affected. Oh, that question, yeah. No, I read a question whether the COVID vaccine could cause dystonia. Yeah, no, the answer is no, or at least based on there haven't been, I don't know what was the context to ask the question, but to my knowledge, there hasn't been any convincing case of dystonia coming up as a consequence of this particular vaccine. COVID-19 vaccines, yeah. I don't know whether there was a specific reason for to ask this question or not, but.
Any more questions?
I just have a general question for Calgary. Is there a support group for dystonia in Calgary?
Yeah.
How do I become a part of that?
Astrid.
I am the president at the Dystonia Calgary chapter. We have posters up at the Movement Disorder Clinic, and I'm an email away. I think we've talked.
Yeah, I was at one meeting, I think, before, but then
Yeah,
I lost your email, or Soraya had told me about you, I believe.
that's correct. I was speaking with her quite often.
Yeah, because I go to their meetings they have them every 2 weeks, and I just attend through Zoom.
We try to have meetings every 3 or 4 months. Most of them have been online lately just because it's hard to get people to come out.
Yeah.
But we're going to keep trying this year to have more and more meetings. But so if you have any topics, please just write an email. It'll be perfect for us. To my knowledge, there's the one in Red Deer. I know Edmonton definitely has one. Carol?
I think we're just adopting the Red Deer area because I'm from the Red Deer area. Oh, okay. So that's kind of how we're approaching it.
We kind of combine.
We're just going to be part of Calgary.
So people in
Yeah.
central Alberta and Calgary and that kind of area can expect emails from me, and it's Alberta support at dystonia.org. So you'll see some emails coming from me. We'll also send a follow-up email to everyone registered for this event. So for those of you looking to connect with the Edmonton group, they will be reaching out to you based on the registration, some of those questions. So those who wanted to be added to information emails, you will be. You'll hear from each group.
I also wanted to say that we're happy to, if you are planning to have a calendar of meetings and activities, I can only speak for the Calgary group, obviously, but there's more than one of us who, the majority of us see patients with dystonia and have experience in dystonia and do injections, and we have the DBS neurologist, obviously, as well, and many other specific expertise areas that. So, if you're interested in organizing, like some library talks or some, events that where we cover a specific topic, I think. That we would be available and happily so, and not just me, but a good number of my colleagues. I'm sure they will be happy. So just take that into account, because in situations like these, I mean, it is also good to structure them in. I love the questions and answer, and at the same time, it's important. I think dystonia is a complex topic, and sometimes when we organize large events, and we are asked to cover broadly areas or to engage into a question and answer that is broad, it's good, it's informative, it's positive for us. We get an understanding of what the community needs to know and wants to know, and what the needs are. But it's also good to break it down in topics, because there are so many areas to cover, and I don't think it's, particularly if we do it in Calgary, I don't think it's not onerous for us to share, to be with you for an hour to talk about a specific area, and I would do it with pleasure, but I'm sure, just like I would, my colleagues would as well. So just keep that in mind.
Thank you so much, Dr. Martino. Dr. Martino and I have been working pretty close together for the last 10, 12 years. A little bit less.
But 8.
8, okay, 8. We've done some media things and some other meetings and research. So, Dr. Martino, on behalf of the Dystonia Medical Group, we want to thank you for being here. And we have a small gift of our appreciation for you. We hope you enjoy it. Thank you. And thank you.